Welcome to Medicine Redefined. I'm Dr. Altamash Raja.
And I'm Dr. Darsh Shah. Let's put the health back in healthcare.
If you're a high performer who wants a clear plan for longevity, performance, and staying active with fewer setbacks, I'm now seeing patients through my telemedicine practice, Refining Health and Performance. I'm opening a limited number of founding member spots at refininghealthrx.com. All right, let's jump in. Dr. Darsh, back for another progress note. How are we?
Good, man. How you doing?
I'm good. I am excited about this topic. I know, as I've joked about this before, you got to be, I guess, pretty lame or a certain stage in your life where you get super excited about lipidology guidelines that come out, or dyslipidemia guidelines, I should say. But I think that it's worth talking about for a couple of reasons. One, the conversations that we've had with the preventative cardiologists on here, Nicole Harkin, William Cromwell, and even Matt from Precision Health Reports. I forget who else we've talked about this. They've been extremely popular. This is stuff that people want to hear about. Clearly, the audience have an appetite for this. But more importantly, when I actually started reading this, because there was some hype about it on social media, maybe I saw, the phrase that came to mind, it was like, what's that thing that they said when the moon landing? It was like one small step for man and one giant step. So I just thought, I was like, oh man, one small step for preventative medicine, one giant step for, longevity medicine is kind of what the thought that I had. And I thought that it would be worth it for us to unpack it a little bit, maybe inform some patients about what actually shifted, and hopefully that they can have these conversations with their primary care physicians, cardiologists, if they're seeing that, and go from there.
Awesome, man. Yeah, I think you nailed it. I think this is going to be an episode where, it hits home for both of us. Obviously, we both have a higher risk for heart disease in our family. And this is something that we've kind of both been on the forefront with testing and just looking at guidelines and supplements and tracking. So this is exciting for me. I'm coming into this with a clean slate. So I'm sure I'm going to have a lot of questions for you. And like you said, I think a lot of our patients hopefully can now go to their doctors and say, hey, look, these are part of the new guidelines that we feel like we've been so behind on, whereas Europe has, been kind of on the forefront with a lot of this testing. But yeah, hopefully they can go to their, they can at least go to their physicians and say, hey, listen to this episode of Medicine Redefined and get with the program. So
yeah. And maybe actually we'll see if your tune changes by the end of this episode, or at least when you reflect on some of this, because I know this is attention that you had a while back when we were looking at your risk profile with respect to whether we should intervene pharmacologically or not. And so I guess with that, maybe I'll kind of just bring people up. The last cholesterol lipidology guidelines came out in 2018. So we're 8 years later, and they've even just changed the name of it, right? And so they were cholesterol guidelines, and 8 years later, now they're calling it the ACC, American College of Cardiology, and AHA dyslipidemia guidelines. And so biggest update in 8 years. It's not a cholesterol guideline anymore. It's more of a generic, or a broad umbrella term rather, I should say, which includes, the scope's been broadened, right? So it includes triglycerides, LP(a), things that people have heard about, certainly longtime listeners. And the three words I think that capture this update for me is the three Ps. It's proactive, it's personalized, and it's precise. All three words that I think that people who are in longevity medicine get off on, right? Hopefully people will get excited. I guess maybe I'll give a general overview, and then, feel free to ask me some questions. And then from there, I think that it makes sense to kind of dive a little bit deeper into every single segment of what I think is relevant. I'll do my best to keep this as digestible as possible. You'll tell me if that's actually the case or not, because as I mentioned, it's over 120 pages. And I'm struggling to kind of keep it all together. I suppose there are 6 big shifts that I was able to break this down for people into. Number one, which is going to be no surprise to anybody who's into this or listens here, is the core philosophy has shifted from wait until risk is high enough to don't let decades of atherogenic exposure accumulate, right? And so treat earlier is kind of the idea. And they are now even more so pushing lifestyle counseling starting in youth. And I'm talking in the adolescent population much earlier on. Earlier pharmacotherapy in young adults. And so that's been the biggest change. We've talked about this with, giving head nods to Dr. Alan Snyderman over from Canada before, talking about 30-year risk profiles. And so here, some of the new equations that we'll talk about are applicable to people as young as 30 years of age, all the way up to 79. And so anybody who has strong family history, we're going to talk about how those risk enhancing factors play in. Number 2 is, as I mentioned, we're going to estimate risk very differently. Historically, they used these things called the pooled cohort equations, which were somewhat basic. Now there's a calculator that people can readily access online. Go actually calculate some of your own risk if you have these things. I encourage you to do that. Maybe we'll do it on here if you want. It's called the prevent calculator. And I think it's the, oh my God, what's this? Preventing cardiovascular events or something like that. That's what it truly stands for. And then number 3 is use different goals and actual target numbers to when you're treating. So the 2018 guidelines, the prior guidelines, they dropped these hard LDL-C targets, and the 2026 restores those specific numbers as well as the non-HDL-C. And we can talk about specifically what these things mean as a refresher for people at every single risk tier. And so the question is no longer, are you on a statin or are you on a lipid-lowering therapy, but rather, did you actually get to the biological target that we're trying to meaningfully reduce your risk? Number 4 is we're measuring more than just LDL. So historically, people would say, okay, good cholesterol, bad cholesterol, and bad cholesterol was LDL, and I'm putting this in quotes. We've talked about why that's very trivial, and we can't reduce it to that. But things like Lp(a) screening, right, in all adults is now a class 1 category. And for those of you who don't know and not in medicine, class 1 is really absolute recommendation. You should definitely do it. ApoB, something that we've talked about a lot, gets a nod as a class 2A category for getting therapy. They're still a little hesitant on making a class 1 category like the European guidelines have, but at least it gets the nod, and there's certain nuance that they add into when it is appropriate. And so the guideline shifts from that to looking at total atherogenic particle number. And then number 5 is escalate therapy systematically, which is good medicine. It's not just statin and done. It's statin first, then add on, but you're trying to get through these goals. And then last but not least, it's take triglycerides and imaging and special populations seriously. CACs, right? So which is the coronary artery calcium scores. You're more formally integrating that, and that could be reclassifying somebody's who might be intermediate risk to high risk or low risk to moderate risk. Vasipa, which is the only pharmacologically great EPA. Icosapent is the name for it, is the only triglyceride drug with good outcomes data. So they talk about that. But they also even reclassify just the whole, instead of ASCVD, which is atherosclerotic cardiovascular disease, to kind of look at the bigger picture. It's called cardiovascular kidney metabolic syndrome. So incorporating, what is your kidney function like? What's your metabolic health? And using that in part of the prevent calculator. So what do you think about that?
Makes sense to me. If I could summarize it, it just sounds like we're getting more aggressive. We're starting to use metrics a little bit more with harder guidelines and finding different multimodal approaches to try and reach those, right? So the LDL less than 55, and then look at ApoB again, which is class 2, but then using risk calculators, right? So not only using 10-year risk, but 30-year risk. So for someone like me who's 34, okay, I can now predict at the age of 64, and I'm using that 34 risk because we know, as you said, it's an area under the curve problem. So I might not feel the effects now, 30 years, I definitely will. Sure. So just like we did with hypertension and diabetes, we're starting earlier, we're getting more aggressive, and we're treating and preventing things earlier.
Yeah. And I think we had talked about this, right? And it's not to say that we didn't have a calculator, but just to kind of drive home that point. Previously, the calculator, the pooled cohort calculator, I think didn't even apply until the age of 40. Mm-hmm. And so for that 33-year-old, such as yourself with South Asian ancestry, myself, 32, when I was arguing with my cardiologist, like, how do we even put that into the framework? You can't, but now you can. And so that old one was built on this 1990s cohort data from Framingham, Cardia. These people are going to remember. It included inputs like age, sex, race, just binary, black versus non-black. Same thing with diabetes. It was yes or no to diabetes. As opposed to now, you can actually put your A1C in and kind of see where and how insulin sensitive, insulin resistant you are. As we've talked about this before, A1C is not just a hard, it's not one day you go to bed non-diabetic, the next morning you wake up diabetic. It doesn't quite work that way, right? That thing has been building up under the hood for months and years.
Right.
And so same idea there. So the new calculator called Prevent, built around the CKM model, like I talked about, it adds GFR, which is a surrogate for your kidney function. Glomerular filtration rate, hemoglobin A1C, I already mentioned. They also include optional urine albumin to creatinine ratio as an input that you could put. All three of these, I think, are optional. It drops race as a variable. I think people talked about that, has some logistical and ethical problems. It gives the both 1030, as you talked about. It's validated on more than 3 million people from contemporary US data. So that's what's cool about this, right? And so this is, the other thing I should mention, this is not just one organization, one society guideline. This is multiple societies coming together and putting this together. So there are a lot of people much smarter than you and I on here putting this together. And it's really cool that they're, again, arguing for the things that at least I feel like I have been fighting the most brilliant lipidologists since I guess I was 30 years old. And then last but not least, but the earlier age range, right? So 30 to 79, it applies to. Anything below 30, you got to apply your clinical judgment. The prevent calculator, I should say, I know you were giving some specific targets. The risk thresholds are like this. So less than 3% on your score, if you see that, it's considered low risk. This is if you actually put your information into the prevent calculator, which again, freely available. We're going to link that for people. Between 3 to 5% is borderline. This is where we'll say you could consider lipid lowering therapy. And I'll just call it LLT for the short for people from now on. 5% or 10% is intermediate risk. They say that it should be considered. And greater than or equal to 10% is definitely high risk and it's recommended. And these flag roughly the same population with the old cohort equation with 7.5 to 20%, but it's a little bit better because it's now considering things that are not captured by the calculator. So they have this thing called a CPR model. So just, shorthands are always good. And C is calculate. We just talked about that. So you'll run the prevent 10 or 30 year. P, my favorite part, personalized. So this is where you layer on risk enhancing factors that are not in the calculator. For instance, family history of premature cardiovascular disease, right? That was a big one for me, which is why I really started arguing, right? So for those who don't know, and I don't know if I've talked about this, right? My mom at the young age of 50, which is considered premature for females. I think for females, anything under the age of 65 is considered premature. For males, is below 55. So she was extremely young and she had her first MI at that range, a heart attack. And so that really got me down this rabbit hole that leads me to read a 120-page guideline today, despite not being a cardiologist. LP(a), elevated LP(a). We can talk about those numbers are for me. That's elevated. High sensitivity CRP. People have heard of CRP, an inflammatory marker. ApoB, again, LDLC, South Asian ancestry. Again, that is the things that we talked about. Other chronic inflammatory diseases, HIV, metabolic syndrome, premature menopause, preeclampsia. So these are all things that can change how you look at the problem in terms of whether or not you can intervene. And last but not least in the CPR is reclassify. So this is where you'll selectively use imaging. They specifically give a nod to CAC scoring to break ties for people. I think you and I can argue where CTA, some of those who are, again, consider ourselves to practicing a little bit more aggressively, truly in the longevity space, will say that CTA actually has a role, and we can talk about that. But yeah, that's kind of the framework for this.
Nice, man. I have no questions about this. I mean, this definitely makes sense. I like how it's a little bit more personalized and it's just easy to follow, right? Like you kind of just go down algorithmically 1, and then wherever you are, step 2, input whatever you need to, and then step 3. So I think it gives you a more definitive kind of pathway as far as what your risk is.
I guess maybe it's worth taking a step back and seeing if maybe you understand and if it's a way if our audience understand those numbers. So LDLC, non-HDL, ApoB, LP(a), we've been throwing this around. And if you go to your doctor and you get a lipid panel, you'll see this number like LDL, non-HDL. Maybe they'll talk about that and they'll say, hey, we're going to target this. But you might have the question is like, why are we targeting this? And again, I've emphasized this, other people smarter than myself said we shouldn't say good cholesterol, bad cholesterol. There's no such thing. But there are things that are atherogenic and can be considered bad. Do you have a clear understanding of every single one of them? Or how do you think about it, I guess?
I mean, I think the LDL is what I get tripped up on most, right? Because you hear both sides, I think, with that in respect, especially like people on ketogenic diets, right? They're going to sometimes be a hyper responder and their LDL will go through the roof to like 300, 350, sometimes 4 without any history of any type of hypercholesterolemia. And so the argument, I think, with the camp that says, hey, you still should bring down your LDL is that, if you look at the data, there's still a huge correlation between heart disease and elevated LDL. On the other side,
I push back. It's more than correlation. At this point, most people will say, yeah, it's very much causative. But go ahead.
But no, okay. So then in that case, like with the hyper responders, I guess I'll throw it back to you then. Like, what is your opinion? Because then you'll see the other side of the camp saying, I mean, there's a lot of people in the carnivore diet camp and whatnot saying, hey, you can still have this improvement or a rise in LDL, but when your inflammation, all your cardiometabolic factors, all the other lab work looks good, you're not really putting yourself at too much of a risk for any type of cardiovascular events.
Yeah. So so I think what you're talking about is the lean mass hyperresponder hypothesis, right? I think it's important for people to understand just because something is causative doesn't mean it's absolutely 100% going to happen. That just means that we know that causes something, and that cause could be tomorrow, it could be 50 years from now, it could be 80 years from now. I just don't know. And the signal is strong enough where we can go ahead and say that. Like smoking being the perfect example for this, right? So people, again, do we have randomized controlled trials? Other people have used this example to say that we have that? No, but we have enough data at a level of strength strong enough where we say, yeah, smoking causes lung cancer. Okay. Hopefully I didn't piss people off with that statement right there. But I'll take a step back and say this. I think that, yes, if you have somebody who has a really high LDL, just through the roof, but like you said, is of Caucasian ancestry and has an extremely low LP(a), has no other atherogenic factors, has blood pressure is dialed in, has no insulin resistance whatsoever, has visceral fat is up, like everything else that we talked about in the P for personalized is just nowhere on even the radar. Is that high LDL alone okay? Probably more okay than another person who has South Asian ancestry, premature family history of cardiovascular disease, right? Like probably more okay. Can we ever say to anybody, you're going to have a heart attack, you're not going to have a heart attack? No, you know this, and I know this, is that we can never look a person in the face and say, this is going to happen. Like it's all risk mitigation. We think it's going to happen. And the other interesting thing about that hypothesis is the people who had the heart attack and died from that hypothesis, they're not the ones out there talking about it.
Right.
So this is a survivorship bias in some sense as well. And I mean, again, I'm not a super attuned to the whole argument from that, but this is one of those things is, we can't be, I guess this might be PSA for my trainees, and I'm curious to get your thoughts on this, is like, you and I are coming into longevity medicine from a PM&R background. And I was thinking about this because, I'm in a group and I talk to people with longevity who come from internal medicine and family medicine. Nobody owns longevity. It's not a specialty. It's not a field. And I think everybody who comes into the field, whatever their specialty is, they look at the longevity problem from their angle, right? I've been advocating for a lot from MSK Health recently because that's the lens that I like to look at the problem from. At least that's the lens that I feel most comfortable and most equipped to comment on. So when it comes to things like lipidology and cardiology, there are people that I trust more than myself on this. There's too much knowledge out there. There's too much information for me to sit there and be the subject matter expertise on lipidology while also being a subject matter expertise. Like I would have to trade off MSK to be able to come back then. Why am I sharing all of this? Because I think that you find a lot of reputable sources and you see where that overall overlap is, and you look for the signal in that. Otherwise, if you just go to the extremes to look for the signal, that it gets really hard. I actually commented on somebody's LinkedIn. I forget this guy from Primary MD. I forget his name. Talking about how people are using poor, weak alternative thinking as an alternative to institutional thinking that's gone wrong. And I thought about that as us because, I think about that. We talk about dysfunctional thinking from an institutional standpoint all the time about how things are the way they are, but that doesn't mean we should replace lazy thinking by that metric. Fair enough. And so the other challenge with longevity, and even this is no longer longevity because it's a guideline, but this longevity space is that it's all in the gray. Everything's in the gray. Right. There's shades of it, but then, the problem with that stuff comes is sometimes we become bolder than what the evidence shows, and that gets really tricky for patients. And that's why another reason I wanted to distill this down, and I got super excited because this is like the first time that I can remember where the quote unquote traditional medical system is like meeting up with what a lot of people who are more proactive, primordial prevention, precise and personalized care for. So what are your thoughts about just the whole idea? I don't want to sidetrack us too much on that.
No, yeah, no, I think you really nailed it. I think it's the first time I'm really seeing, like you said, you see the academic side of things kind of come up with the forefront of the medicine 3.0, social media, people advocating and looking at research from a different angle type mix, if that makes sense. I just think it makes sense. I like how it's multimodal. It's not so black and white. And I think that allows for flexibility and it allows for more debate too. And I think that's what's needed in medicine is more of these type of conversations that we're having right now to kind of go through and say, hey, why is this number we're choosing, or why a 30-year risk, or how does this work? And I think when you start to ask these questions, you tend to go down mechanisms of, certain drugs and how imaging works. And you start to get exploration of all these different things that contribute to why the guidelines are the way they are. But I think that's just better for science.
Yeah. Yeah. And I'll make sure I say this again at the very end, but Notice that I started this whole thing by giving you the model of the CPR. And that's really important because the P in personalize is what's, I think, makes medicine fun. I know you like to practice medicine this way. I like to practice medicine this way. Everybody wants to practice N of one medicine. The problem is when we're communicating on social media, when we're communicating on this podcast, if we have several hundred or 1,000, whatever, at some time, listen to this, the message is not going to be for every single person. And so that's why you kind of have to, when you're ingesting information, you have to think, is that person actually talking to me? And sometimes the answer might be no. And the reality is we can't cover every single case. Maybe if we have time at the end, we'll do a couple of cases for people, but we're not going to be able to cover every single possible scenario. So with that said, I'll just quickly cover like LDL-C, low density lipoprotein C. This is the analogy. Analogy is good. Okay. I was thinking about the way I think about it is they're trucks, right? So all these particles are trucks. And so LDL-C, which is what people used to think and we target, is the cargo weight on the truck. It's a specific type of truck, and that truck is the LDL particle. And it's only measuring the cargo weight on that truck, just that type of truck. And then you have non-HDL-C, right? So it's everything on that lipid panel that's non-HDL. So you basically take your total cholesterol, right? You subtract HDL, you get your non-HDL-C. Now, this is the cargo weight on all of the bad trucks. Because more than just LDL, you have VLDLs, you have IDLs, you have triglycerides. All of these can actually be, and remnants and Lp(a), they can contribute to atherosclerosis, which can be heart disease, brain disease, that kind of stuff. So this is a simple upgrade from the standard lipid panel where non-HDL goal is actually typically, even in these guidelines, about 30 milligrams per deciliter more than the LDL goal, right? But it tracks pretty closely. In certain instances, non-HDL-C is a little bit better, but that matter. So that's where the non-HDL is. ApoB, which we've been advocate for, other people are advocate for, it's actually counting the number of trucks. So LDL-C cargo load on one truck, non-HDL cargo load on all the bad trucks, ApoB counting the actual number of trucks. The reason that's important is people talk about particle size and particle number, and it turns out that the particle number is actually more important because even the smaller trucks with less load are just as problematic as the trucks with lots of load, right? So you actually want to get the number of trucks because that's what's going to dictate what your actual risk is. Does that make sense?
Yeah, that was a beautiful analogy I've never heard before. I love that.
Yeah, so I think that if people look at it that way, that's why a lot of people will argue, well, why are we not getting ApoB and stuff like that? And in some cases, like I said, non-HDL tracks it very closely with a few exceptions with somebody who's insulin resistant, is diabetic. That's where the discordance comes in. You and I have talked about that. Elevated triglycerides, ApoB wins every time. And the guideline actually talks about this, but they still have a 2A check on this therapy that, hey, let's treat it. Little a. Yeah, so this is the LDL particle. This is another big one. This is an interesting, and this is a purely genetic thing. So just a background, it's an LDL particle with a small apolipoprotein on it. I'm not going to get to the mechanisms of it, but it's 90% genetic. And the other interesting, it's stable over lifetime. So you really just need to check it once in somebody's life. And I'm pretty sure like yours is actually quite low from what I remember, right?
Surprisingly.
Yep. So good for you. Mine is unfortunately not. Mine is very high. And we can talk about why I chose to intervene for myself because of that one reason. So there's 3 ways that this is actually responsible for damaging, and they're independent of LDL. That's really important, right? It's proatherogenic. So again, that's creating more heart disease. It's narrowing those arteries. It's pro-inflammatory because it oxidizes fast lipids. Inflammation in this sense inside is not good. And it's prothrombic, as in it causes a lot of clotting to happen. So people who have elevated levels of LPA, they're actually higher risk for clots too. That's why they're also higher risk for aortic stenosis and these other things that are aside from quote unquote coronary artery disease. And this actually ends up being highest in African and South Asian ancestry. And about 1 in 5 people, maybe even a little bit more than that, are walking around with an elevated Lp(a), but a lot of people don't even check it. They've never even heard of this. The doctors never talked about it. You heard me talking to Nicole Harkin back in the day in 2020. It was like, why the hell are we not checking it? And because people have never heard of it. But now they've made this a class 1 recommendation, which is super, super exciting. But you could have 2 people with exactly identical LDL and super, super low and everything be normal. One person have an elevated Lp(a) like 1.5x, and they could be a significantly greater risk just because it's an independent factor for contributing to adverse effects when it comes to heart.
Love it. I got no questions for you, man. Good.
Love it. So maybe the next place is, I won't spend too much time on it because I don't want to make this treatment thing. I think my hope is that people have an idea of how they can think about it, and then they can talk to their cardiologist or their family medicine doctor who can read the guidelines and talk about where the targets are. But, just if you are somebody who has very high risk, like the goals are, initially I said that we have actual targets, right? You talked about less than 55, but it's actually not just that. It's also a percent reduction. We're trying to achieve both. So for somebody who's very high risk, right? Think this is maybe your father, your mother, your grandpa who's had a heart attack, has high blood pressure, and is already on a statin or something like that, or maybe had a stroke. Like now we're trying to get their LDL below 55, their non-HDL below 85, and a greater than or equal to 50% reduction. Somebody not very high risk, 70, 100, and 50. I'm just going to mention LDL, just know that it's plus 30 for non-HDL from now on. Somebody who is intermediate risk, it's going to be less than 100. Somebody who's subclinical atherosclerosis, who has a CAC score greater than or equal to 100, you're trying to get less than 100. And I mentioned earlier, with somebody who has, if you're using the prevent equation and the calculator, and it's for primary prevention, then it kind of really matters a lot on the P and the personalized and the R and the reclassified to see when you're going to intervene. And I think that point is going to be less than 100, really what the LDL-C target goal is going to be. So I think that's kind of where it is. I'll quickly touch on the different agents available to us. We don't have to get into it unless you have a question, because I know other people will have a question. Statins are the tried and true, the most popular. I want to be very clear. I am not in the camp that statins should be in the drinking water, but I do think that they're one of the best drugs available to us, and we have a lot of options. They certainly have problems with them that I've personally experienced, but statins are number one almost always. Ezetimibe, which is Zetia is another name for it. It blocks cholesterol absorption. So statin inhibits a pathway of that cholesterol formation. Ezetimibe blocks absorption. There's a newer drug that came out after the 2018 guidelines, I think. This is called bempedoic acid. Have you heard of this one?
I haven't, no. First time.
Yeah. Bempedoic acid actually works this. You might remember statins, HMG-CoA reductase inhibitor. Remember that?
Yep.
Yeah. So bempedoic acid actually works in that same chain, but maybe 2 steps before. What's interesting and cool about bempedoic acid is it only works in the liver. So it activates only in the liver, that enzyme, or blocks rather. And so you don't get any muscle effects. So there's no myalgias like you do with statins with this one. So that's the indication for this, is when somebody who's statin intolerant because of muscle issues.
So is this now the next step after the intolerance? Because before you used to just go straight to like Repatha, right?
Yeah, this could be a really good option, unless there is some indications for Repatha would surpass it, because Repatha is still much more potent and knocks us out of the park. Like I think the data talks about alone in some of the studies that they cited that 18% bempedoic acid alone, when you combine it with ezetimibe, there's actual pill called Nexlizet. I think that's the brand name for that. That's a 38% reduction in LDL-C and has clear outcomes as well. Like outcomes when we talk about is hard outcomes, quote unquote. And that's what people will say MACE, so major adverse cardiac events. And this is, did taking the medication 10 years down the road prevent a stroke? That's like the most meaningful thing, not just did LDL get better? Because to your point, it's like, who cares if the LDL is high or low? What we're trying to eliminate is stroke, heart attack, that kind of stuff. Repatha, which are monoclonal antibodies, these are PCSK9s. They have a significant effect, 60% additional reduction if you're taking this. But the problem with them, they're very expensive. This, if you have to pay out of pocket, can cost $6,000 to $8,000 a year. This is a Q2 or Q4 week, every 2 to 4 week injectable, sub-Q for most people. But the outcomes are proven it's really, really good. One of the newer drugs is a siRNA, I think, inhibitor. I forget the exact mechanism for this, but it's called inclisiran, or Leqvio is another name for it. It has a similar LDL lowering advantage of this is an injection every 6 months that you have to go in. But the problem is the outcome trials are not completely there. So it works really well, but we don't have them. And so I think they gave it a nod or acknowledgement, but they didn't necessarily recommend it. So to your question, with statin intolerant therapy, what you'd be doing is the combination. Well, maybe you could do bempedoic acid by itself. If you needed aggressive, you would do the combination with ezetimibe and then maybe add on to PCSK9.
Yeah. Was there any mention of supplements in the guidelines now that they're probably looking more for like medicine 3.0?
There absolutely was. I was going to bring that up at the very end, but let's do that. And we can tie into kind of your thought process, because they gave, well, actually, let's do this. I want to wrap up with LP(a) and CAC before we go. So
sure.
Just because I think this is the biggest win. And so I think I've explained LP(a) a little bit, but just for people again. So everybody, if you haven't had it yet, it's not a medical advice, but whatever. Please consider talking to your clinician about getting it, just so you can assess truly what your risk is. I've already mentioned what those are. And it usually comes, you'll see it in two ways, in milligrams per deciliter or nanomoles per liter. Preferably, you want a lab that's actually looking at nanomoles per liter. There are some ways how the assay is done, but there are some, they've quantified it so you can actually see the risk. So if in nanomoles per liter, anything above or equal to 125 is considered the cutoff. Like that's your high risk at that point, which would equate to 50 milligrams per deciliter. And then, of course, every little bit on top of that it's multiplicative risk. It's not just additive. That's another important. And so I talked about this, I think, when I found out, my mom had that issue and my first LP(a) was 207 nanomoles per liter. At that point, I was like, okay, well, we need to consider. And that's when I started having some discussion with some preventive cardiologists. And the interesting thing about LP(a), I should say, at this juncture, we do not have drugs to address it. I mentioned it's an independent risk factor, but unfortunately, we don't have any drugs actively on the market that can directly reduce that. We've got it for LDL, we've got it for triglycerides, we do not have it. So then the question becomes, and this was the question asked of me by my wife, is, well, if there's nothing you can do about it, why even check it? You might have heard this. Have you heard this?
Mm-hmm. Yeah.
Yeah. And the argument that I would make is it risk stratifies you as a person. And you got to assess if that person in front of you, I think I talked about this with Leonard Rhodes, actually, if that information is going to cripple that person or if that's going to empower them. For instance, if you know that you are much higher risk, but there's nothing you can do about that, but you ask yourself, hey, what can you control? So interestingly, they've even talked about this, right? So they've published, AHA published something called the Life's Essential 8, which if you optimize these, it can reduce your overall, observationally at least, 60%, 67% relative risk reduction in terms of just like your overall outcomes, right? And statins actually, even in one study, the Jupiter trial, which was a primary prevention trial way back when, did cause a little bit of reduction as well. But PCSK9s, Repatha specific, can cause about a 15 to 30% reduction. But in the pipeline, there's a trial right now called the Horizon trial. And these things people might hear about ASOs, so angiotensin oligonucleotides, which are directly looking at this to reduce LP(a). But to come back to that essential 8, if I remember, I mean, it's all the other things, right? Can you dial in your nutrition? Can you optimize your sleep? Can you make sure the inflammation is low? Can you make sure your blood pressure is tightened up? Your kidney function is good? What are all the things that you can double down on? So for instance, like at this point, what comes to mind is, let's just say somebody is, sitting in that overweight, obese category. They have an elevated LP(a) and their LDL-C is borderline or maybe even low. Maybe it's not that high. But they were considering whether or not they should get GLP-1 for better insulin management or just insulin, sensitivity and even weight loss. Maybe now, I'm not suggesting this is what people should do, but maybe now your conversation changes a little bit because now you have a stronger reason to consider something like that. You know what I mean? Hey, listen, exactly. I got to get my waist circumference a little bit lower, my visceral fat, that kind of stuff. So I think that's kind of like where I think that I feel strongly why this should be gotten. What do you think about that?
No, I 100% agree. I think too many people in science and medicine kind of think like direct effect, right? Like if you do A, then B automatically happens, right? So if you can't change it, then you don't do anything. But that's not how reality works, right? Because context changes everything. For me personally, I know I have a lower LP(a). Okay, I can almost, kind of F around and find out in a way, right? I have more wiggle room. I can take supplements. I can do more experimentation. I can see maybe what helps and what doesn't before going and jumping to a statin. Now that might change given these new guidelines and kind of what we're talking about. But I think based off the context, it allows me to say, okay, let me double down on lifestyle, activity, nutrition, like you're talking about, which in the long run is going to help so much more. Whereas if I had a higher LP(a), maybe I'd be more prone to saying, okay, right off the bat, let's do a statin, but then focus less on maybe the nutrition and the exercise and what I need to do. And again, people's personalities are going to be different. Their frame of reference is going to be different. But I think it's just another tool in the toolkit that people can use that's going to change the trajectory of their life based off, again, their reality and how they are going to essentially consume and take that number and do what they will with it.
Yeah, it's so funny you said that, the F around to find out, because I think one of the things that I would say earlier when I found this out is like, hey, I can't afford this just because, it's, so when I'd be making a decision between Italian donut or something else, those things are really good.
100% changes it for you. Yeah.
So I guess in one sentence, what I would say is knowing your LP(a) doesn't change the treatment per se, but it does change the urgency on how you might do other things around that. So, and then CAC. So CAC, I think I talked about that. I won't say the different cutoffs that they say where you should intervene because I don't think that matters. But what's also interesting, they even said that if you have an incidental finding of like coronary calcium on a CT, maybe you're doing a CT for lung surveillance for cancer or something like that, coming back to that smoker, and you see actual calcium there, you can treat it. You know, I think it's going to be interesting if cardiologists are going to actually pull the trigger on that, or they're going to say, hey, listen, I actually want a formal coronary CT. So that's TBD at this point. But I thought that was like really interesting for them to kind of be aggressive on that about the reclassification of it.
Yeah, interesting. Do you want to also explain, because I know we've talked about this, right? So a lot of people don't know about the CTA. That's somewhat new. Now you can do AI imaging for it. Kind of when to think about doing a CTA versus a CAC, because I think a lot of people will just go straight for the CAC. That's the most common thing they've heard of in the guidelines, I guess, after 40. But
yeah, coronary artery calcium score, that's the CAC. And really what it's picking up is calcified plaque that's already hardened. It's like scar tissue at this point. So that's indicative. If you have that, the damage is already done. In fact, you're probably lucky at this point because that's formalized, right? What it doesn't pick up is soft plaque. The one that's fungible, the one that's amenable to changing for the better, or, getting cleaned up, getting reabsorbed or oxidized, or the one that's going to actually harden and lay down on those arteries, the lining of those walls, and narrow those arteries, those pipes, so to speak. A CTA actually is going to pick that up. Now, it's a higher risk procedure because there's more radiation. You're actually getting contrast, so there's risks with that. I actually had one. It actually feels really weird. They did warn me that for those who've had it, know this experience. Yeah, you have the flushing when you get the nitro, but you also feel like you peed yourself because it like drops to your system. It's so weird. It actually is a very strange feeling. I actually thought I pooped myself. I wasn't sure. I didn't though, just for those wondering. But to come back to what that actually will look up as a soft plaque. Now, the problem is, so if you think about the younger person, you, 34 years old, what's the likelihood that you're going to have hard plaque?
Yeah, I mean, pretty low, unless depending again, if you have very high severe stuff, then maybe, but lower than.
Because that's the other interesting, I don't people realize that this process of atherosclerosis starts in your teenage years. It's starting very early on, right? Because it's a lifetime exposure, like you said earlier on. So that cholesterol, that LDL is being precipitated in those artery walls much earlier on, since you're 2, 3, when you're building up. And so it's happening. And so depending on what kind of life you've lived and your genetic factors, that kind of stuff, 34, you could have it, but statistically speaking, the chances are low. So in a 34-year-old, a CAC of 0 is not that helpful because you expect it to be 0. But in a 34-year-old, if you have a CAC of 500, I'm really effing concerned for you. So on either, if it's really high in a 34-year-old, that's helpful, obviously. But if it's really low, that's not helpful. So that's where a CTA, I think, can be more meaningful because it's going to pick up on the soft plaque. Now, if you find any soft plaque, you have evidence of disease at this point. So you got to treat at that point, right? Like you don't need to kind of go through the whole calculator at that point. If you made that decision to go ahead and do it, then you have to treat it because you see active disease in the process. And that's coronary artery disease. So the problem is a lot of insurances, if you're practicing that model, they will not pay for this in a young person. You have to have a very clear reason, chest pain, shortness of breath. Like, again, not a lot of 34-year-olds, you'll get chest pain where you're considering coronary artery disease. So that's the challenge. So unfortunately, this is something that a lot of people have to pay cash for. And the good news is radiology clinics know this, and you can shop around. And depending on what part of the country you're in, it could be as little as, I didn't check any like somewhere in the South, but at least when I was shopping around in the greater Philadelphia area, I think the lowest I found it was like $300, right? And that was actually, okay, that's actually pretty good. You got to be very careful though, because sometimes they'll advertise $99, and I promise you that's probably not, that's actually a CAC that they're saying is CTA, but it's not. So you got to be really careful with that, because I almost got tripped up. Does that make sense?
There's also, I see now like cardiology clinic doing CTA with AI. Do you know what that AI is that they did?
Yeah. So man, there's something called FFR. I actually don't remember what it is, but I think it's just, it's a specific way of them to just risk stratify. Maybe we should look this up. Like actually look this up. Let's see here. We're going to do a little live searching. Type in CTA with FFR.
CTA enhances. I'm trying to see what the AI part is.
Yeah, so fractional flow reserve is the one that, it's a standard CT imagery with AI-driven computational fluid dynamics to evaluate blood flow restriction caused by plaque. Yeah, so it's basically, again, a better study, right? To kind of see, I guess, functionality of what you're looking for. So when you build that AN and FFR specifically, then you're looking to see, is that plaque actually problematic or not? So it's actually the next level when you're checking that. It costs more money though. I'll tell you that because I know I got this
definitely more
and
expensive.
I paid a lot more money for this. But anyways, again, there's levels to this, right? Again, I feel like I've quoted Tracy Dew so much on this, the good, better, best philosophy. I think at this point, you're really kind of on that whichever shade of gray and you're having that conversation. So you really need to sit down and have a lengthy conversation about the risk benefits and whether or not it's going to change your management. So I know you and I have talked about that, hey, maybe that could be a decision maker we could talk about. I think that's all I got, but we can get into supplements now if you want.
Yeah, let's do it.
So they had a whole section for supplements on this and triglyceride special populations. And they put supplements in class 3, no benefit. Okay. And here's what they say. They actually quoted, they talked about, I didn't know this until yesterday. There was something called the SPORT trial where it actually compared rosuvastatin with some of the common supplements that people use for this. So fish oil, rosuvastatin versus fish oil, cinnamon, garlic, turmeric, plant sterols, red yeast rice, nature statin, and placebo. And, it was 198 patients. It was only 4 weeks. Okay. Only 4 weeks. So that's a big problem in my opinion of this. What they showed was that rosuvastatin completely blew everything out of the water. 37.9% reduction. No supplement beat the placebo. Garlic increased actually LDL-C a little bit. Now, what are the limitations? Short, as I mentioned, a lot of us who actually use supplementation for medical management will realize that you have to give something some time. We know this to be true for drugs as well. The thing is that statins work really fast. That's the one thing. I tell people within 3 weeks, it should be working. So if you're getting it, I was having this conversation with a patient the other day, and you had it 6 months later, nobody's rechecked your lipids. And it's like, why not? We should see. Supplements take some more time sometimes. And so that might be one thing that I know a lot of people will argue for that. The other thing that I know people will bash the study was funded by AstraZeneca, which is the supplier and producer for rosuvastatin, but they gave like an unrestricted grant for this. And I think this study, don't quote me on this, but I think it was done at Cleveland Clinic. CoQ10 was actually another thing for statin myologists. They talked about this as well as class 3. It actually showed that it really is not that beneficial. So that's actually something that I know, I think cardiologists and people will recommend. I had to try this when I was using statin. I was having some issues, and they know that people a lot of times will purchase it over counter because they read about it. Turns out that it doesn't really help, at least according to their conclusion here. And one exception, supplementation I mentioned, is Visipa, right? But that's EPA, which is, don't ask me to say the whole thing because I don't remember it's an omega-3 fatty acid. But so the main omega-3 fatty acids, EPA and DHA. So echinopoic, whatever acid, it's more cardio. DHA, I think about it as more neurological, more brain related, but that's a prescription. And that's the one that's been studied. Reduce It is the main trial that actually looked at this, and they saw a 25% relative reduction in ASCVD and plus in people who had ASCVD, diabetes, and I think triglyceride reduction as well, and who are on statin. The Strength trial was another one which actually looked at EPA and DHA, which was negative. I think if I'm correct, Reduce It also showed the AFib risk had slightly increased. This is where the conversation came up in like 2021, maybe you remember that. So what are your thoughts about this? Because this is something, why don't you, maybe this is a good time because you and I had the conversation maybe about a year ago and you looked into some supplementation.
Yeah, no, exactly. So I've been kind of managing my cardiovascular stuff simply, or strictly, I should say, through supplementation as well as lifestyle factors. So I just pulled up because I've been using ChatGPT a lot to kind of go through the supplements and what I'm taking. And then I also use Rhythm Health. So I'll explain that as well. But supplementation wise, I'm on a good amount of stuff. So obviously a multivitamin, I do take an omega-3, vitamin K2, along with the vitamin D that's in there. CoQ10, mitochondrial health, creatine, of course, more for weightlifting, iron, been deficient given I'm a vegetarian. Let's see, NAD supplement I just added on, recently just listened to kind of podcasts. Here are the interesting ones: bergamot and black seed oil. Now, according to ChatGPT and looking at Examine and stuff, these are two supplements that actually have more reduction in terms of ApoB. And then at nighttime, I have been using.
What was the first one?
Bergamot.
Bergamot. What is that?
Yeah, it's like almost an oil. That's how I always hear it.
Oil or a plant? What is it?
Yeah, it's a plant. It's a plant that they use at Bergamot Orange. But they crush it up using supplement form. And then at nighttime, the red yeast rice from thorn and berberine, mainly for the reducing inflammation. So with that, that's kind of my stack for the morning and at night. I've been using Rhythm Health. So people probably have heard of Function. I think they're probably the most popular precision medicine type lab company. Rhythm is somewhat similar. They use way less labs. So I think they only check about maybe 12 to 15 labs, but you check it monthly. So I pay a subscription monthly. It's at home test. But the reason I like that is I get more motivation from data that I get more frequently. And then therefore, if I am adding a new supplement or taking something away, I can then see over the next 2, 3 months, did it have maybe somewhat of an effect? Now, my ApoB, when I was, originally testing last year in the summer or earlier last year, was hovering around 110 to like 115. Since I've been doing this now for about, I'd say 3, 4 months, which I agree with you. I think supplements do take a little bit, longer than 4 weeks to kind of set in and work. I've dropped my ApoB to an average around 85 to 90. Still not ideal, right? To kind of where we want to hit the target. But now it's at least let me really focus on driving down my weight. So I feel like I'm over muscled a little bit right now. So I'm still kind of
no such thing.
Right. There is no you're right. There's no such thing. I have
too much muscle. These are real problems.
I am trying to cut down.
Mike Isertel is just losing his mind right now.
Yeah, so I'm cutting down trying to cut down from 185 to around 175, get at a better weight for tennis. And then High Rocks is coming up in October. So I'm trying to train for that as well. But being around 170 to 175 is just like an easier weight to move around. And, we'll see kind of how that does too. Hopefully keep that body fat low. I think that's going to be the biggest challenge, right? Is as you cut, how you preserve that muscle mass. But especially as I'm playing more tennis, I definitely need to cut down more to keep up with some of these better players. But yeah, no, after talking to you though, I mean, I think next step, I've always been wanting to get a CTA. So that's going to probably happen in the next couple months, looking at DEXA scans, kind of seeing where I'm at. I'm also interested in getting a VO2 max test actually, and kind of seeing where I am for that. But I think the CTA will be important. They'll give me more information. And then, if I need to cut down some of these supplements, because again, a lot of people look at like cost, and these supplements can cost more than the actual statin. And I think a lot of people forget that.
A lot more. And not covered by insurance.
Exactly. And people forget that. And so they want to go down this natural route, which is fine, right? I mean, if you're going through good brands that we can trust and stuff, but the question becomes like, are you doing it just because of this fallacy that something is more natural versus doing a statin that's cheaper and probably more effective? So that's kind of the next decision tree.
So then on that note, that's what I want to ask you. Talk me through your thought process of, well, actually, before I do that, some of the earlier mentioned supplements, vitamin K and vitamin D, those are not for your ApoB management. Specifically the bergamot and black seed oil and
the red yeast
rice. Okay. Yeah. The other ones are just for other things that you mentioned, mitochondrial health, that kind of stuff, just for general health. Okay. Are you taking a fish oil too or no?
I did the algae omega-3.
Okay. Yeah. So talk through the thought process of why did you decide to go this route? Because I know you had a conversation with a colleague, but I think a lot of people arrive at this, and I know you highlighted the appeal to nature fallacy. I'm just curious to getting in like your thought process and like why not just go to something that is tried and true? What was your hesitancy?
Yeah, I think the biggest thing is hesitancy, right? Like, do you listen to the Drug Story podcast on statins?
Yeah.
And kind of like,
you sent me the one, it was actually really good. Yeah.
So like, when you think about the general public, I think like in medicine, sometimes we have oversight, right? In terms of like, oh, we have the data, statins are great, boom. My father's taking statins. He's also had the myopathy, from those things. That's always kind of played a role in my mind. And I always felt I'm the type of person where if I take the medication, and this is just my reality for some reason, I take the medication over the supplement, it allows me to slack off a little bit more with the lifestyle modification, almost like how I feel GLP-1s do. So people, I feel like, now that GLP-1s exist, it allows people to become obese or allows people to live maybe not a healthier lifestyle because they know a pill exists. And therefore they can live a certain way and then say, oh, well, it works for a lot of people. Celebrities take it, whatever. It's pretty innocuous, right? And I think statins are marketed the same way in terms of this is pretty like an innocuous, cost-effective medication that works. But it's funny because that's just the way I feel like my brain works when it comes to
that's fascinating.
Knowing how I work with lifestyle modification.
Yeah, this is what I love about the variance in people's psychology because, I find myself to be the exact opposite, where if I have to take a medication, I'm more incentivized to get off the medication and therefore be even stricter and be even healthier. And actually have these conversations with people and they're like, because sometimes you can say, that's the other thing is, if somebody, like, here's how I have this conversation with somebody and say, listen, I don't really want to be on a doc. Can we do this without drugs? Can we do this other ways? I'm like, sure we can. Yeah. It's going to be harder and it's going to take longer to get there. The medication is the most effective, at least. Look, the sport trial had a bunch of issues, but it still shows that. I think if you stress this out to 12 weeks, you're probably still getting a similar effect, that it's knocking them out of the park. And so I asked them, I was like, well, can we start a statin and then get it down, and then you get really dialed in, and then maybe you lose some weight, maybe your visceral fat goes down, your inflammatory HSCRP goes down, and then we get you off. There's no rule that you start a statin and or any medication for that, and you're on it for the rest of your life. Like, this is the conversation that I know our pediatrics, like, same thing with ADHD drugs. We talk about this all the time. It's like, you have to be able to de-prescribe just as much as you prescribe these drugs. Because if we agree, which I think you and I did earlier, that it is a lifelong cumulative area under the curve thing, it's like, anything that I can do to reduce that risk over time is like, why not even over the next 6 months reduce it? That's how I have the conversation. But I think it's just, to your point, it's like, you really have to kind of know what type of person you are. Some people are just really averse to the pill burden. Like, as you were saying, all those supplements, I know you're only taking 3 for specific ApoB, but that's 3 extra pills. Like, for somebody who's already taking a bunch of pills, like, you add 3 more pills, or I can add 1 pill. That cognitive overload of taking extra pills, feeling sick. Nobody likes feeling sick, even if you are sick. Like, there are these little things that I think are really important in the conversation.
It's true, man. Yeah, it's fascinating. And I think you're so right. I think, for people listening to this that are in healthcare, residence training, or whoever you might be, I think it's so important to understand the person in front of you, like you said, right? And having that discussion and seeing kind of what they appeal to, or, whether it's nature fallacy or difficulty doing things. I mean, understand that human psyche is so important. So,
yeah. I want to actually flip the script, and I'm going to share a personal story here and come back and now maybe speak to some of my colleagues. And because I think one of the things that happens, and especially a lot of the cardiologists will say, listen, statin has great data, the whole myalgia stuff. I mean, I see this all the time. And so they'll talk about the nocebo effect. You're familiar with the nocebo effect, right?
Yeah.
For those who are not, basically what that will say is, when, let's say I give you a sugar pill or placebo medicine, and I tell you it's a statin, and you as a person start having some of the side effects from a statin, that's called a nocebo effect, right? Did I describe that correctly? I think I did.
Yeah. So it's essentially something that will have it be a more harmful effect.
And so they'll cite these studies, which actually happened. I'm not saying they're making it up. They'll cite the studies which actually showed that people or placebo had these effects like myalgias. Okay. And they'll say, oh, look, the rate of myalgias was no different than on placebos as opposed to statins. And therefore, statins aren't really causing that. However, if you prescribe that and you have a patient in front of you on that medication and they're telling you they have these things happening to them, whether or not it's nocebo, placebo, or an actual side effect, whatever it is, it's a very real experience that you're going through. And I think dismissing them for, look, it doesn't really happen, this and that kind of stuff, is a way to gaslight somebody. And I think that's kind of what makes, or at least one of the things that makes people distrust. And now they're more likely to go listen to the influencer who is promising them to, I don't know, sit in the sun without their pants so they can kind of whatever.
That's literally what I just thought of before you said it.
That's to reduce their ApoB instead, or red light therapy to reduce their ApoB. That's wild. But that's the kind of shit. So I guess what I'm talking to, and here's where I'll share my story, right? So my experience when I first got on, and I tried multiple statins before, I couldn't tolerate them. The first time I had the experience is I felt, and I started with rosuvastatin. We hit the targets. I was happy with that. But probably about 3 to 4 weeks in, after a really intense lower body workout, I would be incredibly sore the next morning. It happened 2 or 3 times, but I remember at least twice, when you're in so much pain that you were woken up from your sleep type situation? That happened to me 2 times. And I remember having the conversation with my cardiologist, and I said, hey, doc, like, here's the situation. Here's what happened. And I was very clear that it only happened after my lower body workout. His conclusion, well, it's not the statin, it's your lower body workout. No shit. Yes, it is my lower body workout. But what I'm telling you is that the statin is reducing my threshold for having this intense pain. So yeah, one answer could be don't work out, which is not a good answer. And I'm not doing that. Right. Or the other answer is let's look at the drug that's decreasing my threshold for that such intense symptoms to happen. And, like both things were true. Yes, it was my workout, and yes, it was the statin. But just that conversation with the cardiologist was so difficult that ultimately he was great, actually. Like otherwise he was good. He's, a good thought process. And doc, if you're listening, Please, no offense here, no hard feelings. But I ended up not going back. And so it's just these little things that we were having conversation. And then we tried a different one with a different cardiologist. And that almost took me to the ER at one point. I think these things, speaking to my colleagues, is really important. Let's not dismiss the symptoms. The experience that person is having is actually a very real experience. And it's like pain, right? You and I talk about this. Yeah, truly, pain is in your head. Yes, but the experience is real. Like, we're not saying it's not there, but technically you're interpreting it in your head. You know what I mean? So that's my little PSA for my residents and fellows or students, whoever's listening.
Yeah. Nice, man. This has been awesome. Anything else you want to add in there? I think covered a lot of ground.
I think so. I kind of wanted to do a couple of cases, but honestly, I mean, this has kind of been, at this point, people might be sick of this. So maybe just some closing thoughts of, is this going to change your management, your personal stuff, anything?
Yeah, no, I think I'm going to be a little bit more hasty in terms of getting those imaging done and just really being on top of this. Again, like, to me, I know that's an area under the problem curve, but I still feel young. You know what I mean? Like, I feel like I'm 20, and I think that's an issue as well. And that's dangerous. So it's dangerous. But yeah, no, I think taking more control of my health, right, in terms of this cardiovascular disease. I mean, this is the biggest thing in my family that I know of runs. Obviously, I've been blessed genetically somehow because my brother's honestly the opposite, with his Lp(a). So it's very interesting how he got a higher one, I got a lower one. My mom doesn't have any heart risk. My dad does. So it's kind of like, I don't know where I fall in that, but getting this imaging will at least help. And
that family thing is not uncommon because, interestingly, both of my parents who are on a CAD, they're both LP little is normal or low.
Really?
Wow. Yeah, even my mom. I for sure, but when before this happened, when I learned about it, I made my cardiologist order it for my mom, and I was like, that's got to be it, and it wasn't. So again, this is interesting. I made a strong case about it being independent, but it's like, what caused it for her? Like, she, other than from hypertension and hyperlipidemia, which is just high cholesterol, she never had anything wrong with it. So we don't have all the answers. Like, we have strong signals, but there are no absolutes, and there's exceptions to every rule. So this is not to say that if you have a high LDL and high this, you for sure are getting a heart attack. That's not to say that. You might be that unicorn who can go on for the rest of your life. But, usually it's the whole, like the thing that we talked about, people are so preoccupied with microplastics when we know so little about microplastic, and they so boldly claim they're willing to do that. Yet we have a strong signal here and they're not. So hopefully this is the framework. Remember, CPR, P in personalize, really important. Recalcify. So much atherosclerosis. Reclassify, excuse me, right? And I think that's going to be good. And then remember, just you can go calculate. Just at the very least, please have the conversation. Take agency into your own hands. It's your health. You have to be the advocate for it. I know you and I have talked about this for 6 years now. Yeah. I'll leave it there for people.
Yeah. And hey, maybe if people are hanging around for this long, join our newsletter. Maybe we do a newsletter with our cases and can kind of talk about that for people.
There you go.
So that could be a cool thing. So sign up at medicineredefined.com.
Medicine Redefined. There you go. Awesome. Yeah. All right, man. Let's sign off. Until next time.
All right, man. Cool. Thank you.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We also want to thank our team for the production of this podcast, specifically Ethan Ju on video, Haritha Yepuri on social media, Zanab Lugmani on research, and Sarah Khan for newsletter. Oh, and if you want to get similar bite-sized information delivered to your inbox every Sunday, please be sure to sign up for our newsletter. Also, if you enjoyed the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimers. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.